Today, we're going to review evidence-based alternative and complementary therapies used in the management of mild to moderate depression and anxiety. My goal is not for you to memorize a list of supplements or therapies. Instead, I want you to think like a clinician who is often asked by patients, "What about yoga? What about supplements? What about CBD?" We'll first review key content, what the evidence actually shows, what's safe, and what's not. Then we'll move into knowledge check questions. This mirrors how you should reason in practice, comparing options, weighing evidence, and identifying safety concerns, especially around pregnancy, drug interactions, and unrealistic expectations. Before we get into specific therapies, I want to ground us in a few key concepts that frame this entire lecture. First, depression and anxiety are extremely common in U.S. adults, and the majority of cases fall into the mild to moderate range. That matters because this is the population where patients are most likely to explore alternative or complementary options, either on their own or alongside conventional treatment. Second, many alternative therapies, such as exercise, mindfulness practices, and expressive therapies, have real evidence of benefit, particularly as adjuncts. These are not fringe ideas, but they are also not interchangeable. Some have much stronger data than others. Third, when we talk about supplements, herbal products, vitamins, and minerals, we need to be especially careful. Natural does not mean safe, and it certainly does not mean free of drug interactions. This slide highlights the high-yield takeaways I want you to walk away with before we even get to the questions. First, exercise is not just a nice add-on. For patients with mild depression, exercise can be used as initial monotherapy, particularly when patients are hesitant about medication or face barriers to psychotherapy. That's an important counseling point and one you'll see reflected in several of the questions. Second, light therapy has some of the strongest evidence among alternative modalities, especially for seasonal depression. When used correctly, at the right intensity and duration, it can be as effective as pharmacologic treatment for some patients. Third, St. John's wort is a great example of why we have to be careful. It works for mild to moderate depression, but it also has major drug interactions, including with antidepressants and hormonal contraception. This makes it a high-risk option if providers aren't asking the right questions. Finally, zinc represents a broader category of supplements that show promising adjunctive benefit, but not as standalone treatments. The evidence here is preliminary, but clinically relevant when patients are already on antidepressants and asking about supplements. As we move into the knowledge checks questions, notice that many of the distractor options are things that sound reasonable, but don't quite match the evidence. This slide is here to anchor us in scope and relevance. When we say depression and anxiety are common, we mean very common. In the United States, approximately 1 in 5 adults, about 20%, live with a mental illness in any given year. Prevalence is not evenly distributed across the lifespan. Young adults, particularly those between 18 and 25 years of age, have the highest rates of mental illness. This matters clinically because this age group is also more likely to seek out alternative therapies, supplements, and non-traditional approaches, often before ever seeing a psychiatric provider. When we look specifically at depression, about 8.3% of U.S. adults experienced at least one major depressive episode in 2021. That number may seem lower than the overall mental illness prevalence, but remember, many people experience anxiety, subthreshold depression, or mixed symptoms that still cause meaningful impairment. These numbers help explain why alternative therapies come up so often in practice. Many patients fall into the mild to moderate range, may be waitlisted for therapy, hesitant about medication, or looking for something they feel they can control. As we move into the knowledge check questions, pay attention to how small changes in percentages or age groups can make an answer incorrect, even when it sounds close. Precision matters, both on exams and in clinical counseling. When we talk about the burden of mental illness in the United States, it's important to ground ourselves in current epidemiologic data. National data show that mental illness is not a rare or fringe issue. It affects a substantial portion of the adult population. This includes a wide spectrum of conditions, from anxiety and depression to more severe psychiatric disorders. These estimates include any mental illness, not just those that result in hospitalization or severe impairment. Most cases fall into the mild to moderate range, which is exactly where alternative and complementary therapies most often come into the conversation. So, what percentage of U.S. adults lived with a mental illness in 2021? The correct answer is 20%, which corresponds to 1 in 5 adults. From a clinical standpoint, this number reinforces why routine screening and patient education, including discussions about alternative therapies, are part of everyday practice, not specialty care. When examining patterns of mental illness across the lifespan, prevalence is not evenly distributed by age. Younger adults consistently report higher rates of mental illness compared with older populations, a trend that has been reinforced by recent national data and further amplified by social stressors, economic instability, and the COVID-19 pandemic. This is particularly relevant clinically, as younger adults are also more likely to experiment with alternative therapies, supplements, and non-traditional approaches to managing mental health symptoms. With that context in mind, the knowledge check question asks, which age group had the highest prevalence of mental illness in 2021? The correct answer is 18 to 25 years. Adults in this age group had substantially higher rates of mental illness compared with those aged 26 to 49 and those aged 50 and older. The option suggesting that all age groups were equal is incorrect, as clear age-related differences are consistently observed. From a clinical perspective, this reinforces the importance of targeted screening, education, and counseling around safe and evidence-based treatment options for younger adults. Depression represents one of the most common mental health conditions affecting adults in the United States, and its prevalence helps contextualize why both conventional and alternative treatment strategies are so frequently discussed in practice. While anxiety disorders are more prevalent overall, major depressive episodes remain a significant source of functional impairment and healthcare utilization. National data from 2021 indicate that a meaningful proportion of adults experienced at least one major depressive episode during the year, most often within the young adult population. With that context in mind, the knowledge check question asks, what percentage of U.S. adults had at least one major depressive episode in 2021? The correct answer is 8.3%. The lower estimate of 5.5% reflects the prevalence of serious mental illness rather than depressive episodes, while the higher percentages of 15.2% and 20.6% overestimate the national prevalence of major depressive episodes. Exercise has become one of the most consistently supported non-pharmacologic interventions for depression, with a growing body of research demonstrating meaningful benefit across a range of populations. Not all forms of exercise show equal effectiveness, and much of the benefit appears to come from activities that combine physical movement with aerobic or meditative components. Large meta-analyses evaluating exercise for depression have shown that several different modalities are effective rather than a single superior approach. With that context in mind, the knowledge check question asks, which form of exercise has shown the greatest benefits for depression according to meta-analyses? The correct answer is mixed forms. Options that isolate a single form of exercise, such as weightlifting alone or yoga alone, are incorrect because the evidence supports multiple modalities rather than one exclusive approach. High-intensity interval training, while beneficial for physical fitness, has not demonstrated superior or consistent antidepressant effects compared with these other forms. Clinically, this reinforces the importance of flexibility when counseling patients, encouraging movement that is accessible, sustainable, and aligned with patient preference rather than prescribing a single best type of exercise. Yoga is one of the most commonly requested alternative therapies for depression and anxiety, and it has been studied in a variety of forms and settings. While yoga is often perceived as a long-term lifestyle practice, the evidence suggests that measurable benefits can occur within a relatively short time frame, particularly for individuals with mild or new-onset depressive symptoms. Research evaluating yoga for depression has generally focused on structured, time-limited interventions rather than years of practice. With that context in mind, the knowledge check question asks, how long should yoga be practiced to improve symptoms of mild or new onset depression? The correct answer is 1 to 2 months. Shorter durations, such as 1 to 2 weeks, are typically insufficient to demonstrate meaningful symptom improvement, while longer durations like 6 to 12 months or multiple years are not required to see benefit and are not supported by the available evidence. Clinically, this is helpful when counseling patients, as it allows providers to set realistic expectations and encourage time-limited trials rather than framing yoga as an indefinite commitment. Expressive therapies are designed to integrate creative or artistic expression with conventional therapeutic approaches, and they have been studied across a range of populations and age groups. These therapies may include music, art, dance, drama, poetry, or creative writing, and they are often used as adjuncts rather than replacements for standard treatment. The strongest and most consistent evidence for expressive therapies is in the treatment of depression, where regular, structured sessions have demonstrated modest but meaningful symptom improvement. With that context in mind, the knowledge check question asks, which form of therapy combines artistic expression with conventional therapy and has shown benefit for depression? The correct answer is all of the above. Music therapy, art, and dance therapy have each shown benefit in clinical studies, particularly when incorporated alongside conventional treatments. Selecting only one of these options would be incorrect because the evidence supports multiple forms of expressive therapy rather than a single superior modality. Clinically, this reinforces the importance of aligning therapeutic recommendations with patient interests and strengths, as engagement and enjoyment are key contributors to the effectiveness of expressive interventions. Light therapy, also referred to as bright light therapy or phototherapy, has one of the strongest evidence bases among alternative modalities, particularly for the treatment of seasonal depression. Its effectiveness depends not only on exposure to light, but on using the correct intensity, distance, and duration. Studies evaluating light therapy have consistently used structured daily exposure periods rather than brief or excessively prolonged sessions. With that context in mind, the knowledge check question asks, what is the recommended duration of bright light therapy for seasonal depression? The correct answer is 30 minutes to 3 hours daily. Shorter durations, such as 5 to 10 minutes or 15 to 20 minutes, are generally insufficient to achieve a therapeutic effect, while very long exposures of 4 to 6 hours are unnecessary and not supported by the evidence. Clinically, this is an important counseling point, as patients often assume more exposure is better, when in fact, appropriate dosing is what drives benefit and safety. Among herbal supplements used for mood disorders, some products have been studied far more extensively than others, and a small number are even referenced in clinical guidelines. St. John's wort is one of the most well-known examples and has been evaluated in numerous clinical trials for the treatment of mild to moderate depression. While its use remains controversial due to variability in product quality and safety concerns, the evidence base supporting its antidepressant effect is substantial compared with many other herbal options. With that context in mind, the knowledge check question asks, which herbal supplement has been extensively studied for mild to moderate depression and is discussed in some clinical guidelines? The correct answer is St. John's wort. Lavender, turmeric, and ashwagandha have been studied for mood symptoms, but none have the same depth of evidence or guideline-level discussion for depression as St. John's wort. Clinically, this distinction is critical because stronger evidence does not automatically translate into safer use. Although St. John's wort has demonstrated antidepressant effects in patients with mild to moderate depression, its use raises significant safety concerns related to drug interactions. Unlike many supplements that have minimal pharmacologic impact, St. John's wort directly affects hepatic drug metabolizing enzymes, which can alter serum concentrations of a wide range of medications. This makes it particularly risky when patients use it without provider knowledge. With that context in mind, the knowledge check question asks, what is the main concern with St. John's wort in terms of drug interactions? The correct answer is that it induces cytochrome P450, CYP3A4, This enzyme induction can significantly reduce the effectiveness of many medications, including antidepressants, oral contraceptives, immunosuppressants, and anticoagulants. The option suggesting CYP inhibition is incorrect, as St. John's wort increases enzyme activity rather than blocking it. It is also incorrect to assume that St. John's wort has no significant drug interactions or that it only interacts with antidepressants, as its interaction profile is broad and clinically significant. From a clinical standpoint, this question highlights why careful medication reconciliation, including supplements, is essential to patient safety. Some herbal supplements have been studied primarily for either depression or anxiety, while a smaller number have shown benefit across both symptom domains. Identifying which products have evidence for both conditions is important, particularly when patients present with overlapping anxiety and depressive symptoms, which is common in clinical practice. With that context in mind, the knowledge check question asks, which herbal supplement has shown benefit for both depression and anxiety in clinical studies? The correct answer is saffron. Clinical trials have demonstrated that saffron can improve depressive symptoms and has also shown modest benefit for anxiety, although the evidence for depression is stronger. Kava has evidence for anxiety but not depression. Lemon balm is primarily studied for anxiety and stress, and turmeric has more limited and inconsistent evidence across mood disorders. Clinically, this reinforces the importance of matching a supplement's evidence base to the patient's symptom profile rather than assuming broad benefit across conditions. When discussing herbal supplements in clinical practice, dosing is just as important as selecting the appropriate product. Many supplements are either underdosed by patients or taken in amounts far exceeding what has been studied, which can limit effectiveness or increase risk. Saffron is a good example of a supplement with relatively consistent dosing across clinical trials for depression. With that context in mind, the knowledge check question asks, what is the recommended daily dose of saffron for mild to moderate depression according to the WFSBP and CANMAT guideline? The correct answer is 30 milligrams daily. Lower doses, such as 15 milligrams, have not been shown to be effective, while higher doses like 60 milligrams or 100 milligrams exceed the amounts typically evaluated in clinical studies and may increase the risk of adverse effects. Clinically, this highlights the importance of evidence-based dosing when counseling patients who choose to use herbal supplements alongside conventional treatment. Aromatherapy is often viewed as a low-risk, non-invasive approach for managing anxiety, and several essential oils have been evaluated for this purpose. While many scents are marketed for relaxation, only a small number have demonstrated consistent benefit in clinical studies, particularly for both chronic and situational anxiety. Lavender is the most extensively studied in this context and has been evaluated using both oral preparations and inhaled aromatherapy. With that context in mind, the knowledge check question asks, which alternative therapy has shown benefit for both chronic and situational anxiety when used as aromatherapy? The correct answer is lavender. Peppermint and eucalyptus are more commonly associated with alertness or respiratory symptoms rather than anxiety reduction, and tea tree oil has not demonstrated anxiolytic effects in clinical research. Clinically, this distinction is important when counseling patients, as it helps set realistic expectations and discourages the assumption that all essential oils have equivalent mental health benefits. Kava is an herbal product that has been used traditionally for its calming and anxiolytic effects and has gained popularity in the United States as both a supplement and a recreational beverage. While some studies suggest modest benefit for anxiety, its use is limited by significant safety concerns. Among these, liver toxicity has emerged as the most serious and well-documented risk, leading to regulatory warnings in several countries. With that context in mind, the knowledge check question asks, what is the main safety concern with kava supplements? The correct answer is hepatotoxicity. Cardiovascular, renal, and neurotoxic effects are not the primary risks associated with kava and are not supported as major concerns in the literature. Clinically, this question underscores the importance of screening for liver disease and counseling patients on the risks of combining kava with alcohol or other hepatotoxic substances. Pregnancy introduces a unique set of considerations when discussing alternative and complementary therapies, as many supplements lack robust safety data and some carry theoretical or documented risks to the developing fetus. Certain herbal products are of particular concern due to their potential effects on uterine tone or hormonal pathways. Ashwagandha is one such supplement, with a long-standing concern for possible abortifacient activity based on its traditional use and limited safety data. With that context in mind, the knowledge check question asks, which herbal supplement is considered unsafe during pregnancy due to its potential abortifacient activity? The correct answer is ashwagandha. Lavender and lemon balm lack sufficient safety data but are not specifically associated with abortifacient effects, while saffron raises concern at medicinal doses but is not the supplement most clearly linked to abortifacient activity in this context. Clinically, this question reinforces the principle that absence of safety data does not equal safety and highlights the need for conservative counseling during pregnancy. Cannabidiol, or CBD, has become widely available and is often perceived by patients as a safe, natural option for managing anxiety and stress. However, despite its popularity, the evidence base for CBD in mental health is limited, and its use during pregnancy raises significant safety concerns. Available data, largely derived from animal studies, suggest potential risks to fetal development, and product quality issues further complicate safety assessment. With that context in mind, the knowledge check question asks, what is the main concern with using CBD supplements during pregnancy? The correct answer is risk of developmental toxicity. There is no evidence linking CBD use to maternal hypertension, gestational diabetes, or preterm labor as primary concerns. Clinically, this highlights the importance of counseling pregnant patients to avoid CBD products altogether. Given both the potential for developmental harm and the high likelihood of product contamination with THC. Vitamins have long been studied for their potential role in mood disorders, particularly as adjuncts to conventional antidepressant treatment, rather than as standalone therapies. Among the various vitamins evaluated, some show inconsistent or minimal benefit, while others appear to enhance antidepressant response when used appropriately. Folic acid, in particular, has the strongest and most consistent evidence supporting its use alongside antidepressants, especially in individuals with low folate levels. With that context in mind, the knowledge check question asks, which vitamin has shown the most convincing evidence of benefit for the treatment or prevention of depression when used in conjunction with conventional antidepressants? The correct answer is folic acid. Vitamin B12 and vitamin D have been studied, but their evidence is less consistent or more population-specific, while vitamin C has not demonstrated meaningful benefit in depression treatment. Clinically, this reinforces the importance of considering targeted supplementation based on evidence and patient-specific factors, rather than recommending vitamins indiscriminately. Vitamin D has received considerable attention in recent years for its potential role in mood regulation, particularly in individuals with depressive symptoms and low baseline vitamin D levels. While supplementation alone is not considered a primary treatment for major depressive disorder, evidence supports its use as an adjunctive therapy at appropriate doses. Clinical guidelines provide a dosing range that balances potential benefit with safety. With that context in mind, the knowledge check question asks, what is the recommended daily dose of vitamin D for adults with major depressive disorder according to the WFSBP and CANMAT guideline? The correct answer is 1,500 to 4,000 international units daily. Lower doses, such as 400 to 800 international units or 1,000 to 1,500 international units, may be insufficient to achieve therapeutic benefit, while very high doses of 5,000 to 10,000 international units exceed guideline recommendations and may increase the risk of toxicity. Clinically, this underscores the importance of evidence-based dosing and monitoring when incorporating vitamin D into a treatment plan. Minerals have also been evaluated for their potential role in mood disorders, particularly as adjuncts to conventional antidepressant therapy. While several minerals are essential for neurologic and metabolic function, only a few have shown preliminary evidence suggesting a possible benefit in depression when used alongside standard treatment. Zinc has emerged as the most promising in this category, with studies indicating it may enhance antidepressant response rather than serve as an independent treatment. With that context in mind, the knowledge check question asks, which mineral has shown promising preliminary findings for use in depression when used in conjunction with conventional antidepressants? The correct answer is zinc. Magnesium, calcium, and iron are important for overall health, but they have not demonstrated the same level of adjunctive benefit for depression in the available research. Clinically, this reinforces the idea that supplementation should be targeted and evidence-informed rather than broadly applied based on general wellness claims. Acetinosyl L-methionine, commonly referred to as SAMe, is a naturally occurring compound involved in methylation processes in the body and has been studied for its potential antidepressant effects. Unlike many supplements, SAMe has been evaluated in multiple clinical trials, often as an adjunct to conventional antidepressants, with dosing playing a critical role in both effectiveness and tolerability. With that context in mind, the knowledge check question asks, what is the recommended daily dose of SAMe for depression according to clinical research? The correct answer is 800 to 1,600 milligrams daily. Lower doses, such as 200 to 400 milligrams or 400 to 800 milligrams, are generally subtherapeutic, while higher doses of 1,600 to 3,200 milligrams exceed commonly studied ranges and may increase the risk of adverse effects. Clinically, this highlights the importance of using evidence-based dosing when patients choose to incorporate supplements like SAMe into their treatment plans. As you move forward in practice, remember that alternative therapies are not about replacing evidence-based care, but about integrating patient preferences with clinical judgment and safety. Many of these approaches have real evidence for mild to moderate symptoms, but none are risk-free. Your role as a PMHNP is to help patients sort through what is supported, what is overstated, and what may actually be unsafe, especially when pregnancy, drug interactions, or medical comorbidities are involved. When you can explain not just what works, but why and for whom, you're practicing thoughtful, patient-centered psychiatric care.